Professor NIVINE CHALABI. She's going to present to us contrast-enhanced spectral mammography guided biopsy. I know this is a very new subject, an issue, and Professor NIVINE is one of the very eminent professors that dealing with all the new applications in breast imaging. Professor NIVINE.
Good evening, everybody. Dr. Ashraf, thank you for the introduction, for your kind introduction. It's a pleasure for me to share in this eminent scientific meeting. And as we just mentioned, Dr. Ashraf mentioned, that my talk is about contrast-enhanced mammography-guided biopsy. I have no actual or potential conflict of interest or financial fund in relation to the content in this presentation. And let's start with what is contrast-enhanced spectral mammography. It's a standard mammography with the injection of an iodinated contrast agent to improve lesion conspicuity, producing two sets of images. A low energy one, which is just similar to the regular digital mammography, and a recombined image which shows only the areas of contrast medium uptake. Why do we do it? We do it with the breast MRI, which are the contrast studies for locoregional staging and finding additional lesions away from the index tumor. In case of MRI and spectral mammography, around 2/3 of these lesions will be malignant and have the potential to affect the management plan of the patient. It is ultimately important that any additional lesions has to be biopsy proven as malignant before doing any alteration, or else we'll have unnecessary mastectomies or inappropriate breast conservation. What about finding a suspicious lesion by MRI or contrast mammography and they are occult on ultrasound? This is an example of the cases that we meet in our everyday practice. Heterogeneously or even extremely dense breast with a left invasive ductal carcinoma. Owing to the breast density, mammography with contrast was indicated. We found the multifocality on the left side and two foci on the right side. We could not find them by ultrasound, and this is a dilemma that we meet every day. So what do we do if we find a new lesion by MRI? We start by looking with, reviewing the mammography and having a second look ultrasound. If it's visualized by mammography, then stereotactic biopsy. If ultrasound, then ultrasound for guidance. If not visualized, then we perform contrast-enhanced mammography, which can be done in the same setting, and we proceed to the biopsy under a contrast mammography guidance. And reviewing the MRI would give us a hint whether the lesion will be better visualized in the CC or the ML view. Contrast mammography biopsy, where to start? Again, by a second look ultrasound, visualized, then proceed for biopsy, not visualized, then use it as a guidance for biopsy. The first step in any mammographic guided procedure, be it stereotactic or contrast enhanced, is a complete review of the case to define the location of the lesion in the breast, the patient's characteristics such as the breast thickness or any physical limitations. And the optimal approach should be planned on the diagnostic contrast mammography that led to the indication. This is an example of a case of stereotactic biopsy that I met a few days ago, where there is, I don't know if you can see, yes, here, there is a cluster of suspicious calcification in the lower inner quadrant, and I had to measure the distance from the lateral and medial aspects of the breast, lower and upper aspects of the breast. It would have been best approached from the lower aspect. However, I hadn't accepted the vertical tool, so I had to go from the inner aspect. How is it done? It's a regular contrast-enhanced mammography. After 2 minutes interval, the patient is positioned, and the target lesion is expected to be found. Where it is expected to be found will be centered in the compression pedal, and a dual energy image is acquired at 0 degree, which is the scout view. It is always possible to toggle between the low energy and the recombined energy images. A pair of images plus or minus 15 degrees is taken, and each image of the stereotactic pair you can toggle again between the recombined and the low energy. And then after the angled image are taken, the target is identified, sent to the machine so that the device can calculate the 3 location coordinates, the X, Y, and Z, allowing the biopsy needle holder to be automatically positioned, just as with the stereotactic biopsy. Following targeting, the needle holder is moved into the correct position. 3 milliliters of lignocaine are injected for local anesthesia, and we would choose and use the 14 gauge core biopsy or the VAB, which is mostly preferable. Then a single image is taken to verify the needle tip placement at the tip of the enhancing focus. We do check images post-biopsy to verify a satisfactory clip placement. This is the whole procedure from injection to the biopsy clip positioning is around 15 minutes. So how about MRI biopsy versus contrast-enhanced spectral mammography biopsy? The availability, MRI guided biopsy in Egypt is not available in any center. And if it is abroad, scheduling magnet time for the procedure may lead to further delays in the diagnostic pathway. It's more expensive, it's technically more challenging. It's more convenient for the females to do a CISM examination over an MRI. It's shorter, lower noise, and improved comfort. And of course, the contraindications of the MRI. The time in diagnostic pathway, it can be performed, the contrast-enhanced mammography biopsy can be performed in the same setting while the patient is attending a second look ultrasound, reducing the diagnostic pathway time. And the procedural time itself, it's around 16 minutes for CISM biopsy compared to around 60 minutes for the MRI. So in 2021, an article said that contrast-enhanced spectral mammography guided biopsy is a new technique that can be successfully used as an alternative to MRI guided biopsy. The add-on for contrast-enhanced mammography biopsy is readily available. It's an add-on to the machine. They have a vertical stereotactic biopsy and a horizontal stereotactic biopsy for those lesions who occupy very difficult and challenging positions in the breast. This is an example from the literature for a female attending a breast screening. There is a right retroareolar architecture distortion by tomosynthesis. It was visualized and biopsied by ultrasound, returned an invasive lobular carcinoma grade 2. Owing to the dense breast and the tumor type, the MDT decision was to do a contrast study, which was an MRI for local staging. The index mass was seen with 2 posterior nodules which were suspicious. Because of the level of suspicion, ultrasound-guided biopsy was attempted. However, it was not in the right place because after inserting the clip, it was found that it is inserted in the hematoma anterior to the index mass. However, the suspicious focus was posteriorly located. So a contrast-enhanced mammography diagnostic one was done, and the lesion was centered in the paddle. A recombined image plus 15, because after we insert, we put the needle into the biopsy site, we take only one image, which is here a plus 15, and the biopsy accurate needle placement was confirmed. The pathology returned as an IDC, and the patient had a mastectomy. Another example of a 61-year-old female with known right-sided HER2 plus IDC grade 1. After contrast mammography, there were 2 lesions, 2 foci suspicious present in the left breast at 12 o'clock. Biopsy was attended again by ultrasound, clip inserted, the location was not right, and there was no pathological confirmation. So another study was done, which was an MRI to confirm the level of suspicion by an ADC and diffusion sequence. And the lesion was restricted in diffusion, so the decision was made to do a contrast-enhanced mammography biopsy. As you can see, the confirmation of the needle in place was done, and then a clip was marked, and it was in the right position, and it returned, the pathology returned as a grade 2 invasive lobular carcinoma. Another example of a lesion of a patient that is 78-year-old with right-sided mass. The diagnostic mammography was negative. Dense breast, MRI, we found 2 lesions. The lesion that was seen by ultrasound, which is the posterior one, it was biopsied, and the second lesion could not be visualized by ultrasound. So contrast-enhanced mammography was done. As you can see, you can toggle between the low energy and the recombined images. The plus and minus 15 pair was taken. The needle position was confirmed pre-fire, and then the biopsy was taken and the clip was inserted. This is another example that I met a few days ago of a 40-year-old female with positive family history. Her physician insisted, despite the patient did not have a palpable lump, to do a contrast-enhanced mammography. As you can see on the right side, there is a segmental clumped non-mass enhancement that was suspicious at the time. I did an ultrasound and couldn't find any lesions to biopsy, so the patient was referred to a center where contrast-enhanced mammography biopsy was available. The biopsy was taken and returned as PASH. How about compression? In the regular contrast-enhanced mammography procedure, we wait 2 minutes until the contrast has reached the lesion before we start the compression, so as not to interfere with the blood flow in the breast. However, luckily, in the biopsy setting, the compression that we do minimizes the lesion washout, giving us a window of time which is sufficient for proper targeting. What are the clinical limitations? The pregnancy, allergy to iodine, renal disease, and genetic high-risk women, especially BRCA1 mutation, because they are very radiosensitive. The same as the biopsy, the anticoagulation treatment, and the need for an INR, a recent INR. And another limitation, that is, we should not be using a skin cleanser containing iodine, or it will affect the visibility in the recombined image and might impact the image quality and cause an artifact. Some important points to keep before the biopsy, because the biopsy time is limited. This is a contrast study. The preparation phase of the clinical case is even more crucial in contrast than in stereotactic, so as to limit the risk of missing the lesion due to the washout. It is recommended to realize a lateral view at the end of the contrast-enhanced mammography routine exam. It is recommended to wait 48 hours between CISM routine and CISM biopsy, just as the CT, and it is recommended to use preferably VAB needles, as in MRI, to have a good tissue sample. How about during the biopsy? The patient should not be compressed during the entire injection, just as the regular one. We wait 2 minutes before compressing the breast on the biopsy robot. It is strictly forbidden to use betadine for this infection, just as I said, mentioned before, because the iodine in it can create an impact on the quality and cause an artifact. It is recommended to perform 2 full turns of sampling, just like in MRI, and recommended to deploy a clip for future reference. So my take-home messages is that while performing contrast-enhanced studies like MRI and contrast-enhanced mammography in dense breasts, aiming at loco-regional staging, new suspicious lesions appear which need pathological verification prior to altering treatment management. These lesions are sometimes occult on mammography and ultrasound. So contrast-enhanced mammography guided biopsy is a relative, non-expensive, readily available, easily to perform tool to substitute MR guided biopsy. The contraindications and precautions while performing the biopsy have been entailed in detail and put in consideration. Thank you very much for your attention, and I'm open to any questions.
Thank you very much, Professor NIVINE, for your presentation. We will postpone questions till the end of the session. Thank you very much. Now we'll call on our next speaker, Professor